Judith, welcome. Have we, Rina?
Yes, hello.
Hi, Lena. Hi, Judith. Salim, I can't see Suzanne. Is it my... let me quickly just send our WhatsApp.
Okay. I don't see her also.
And as participant, log in to join the webinar, just to let you all know that first greetings to you all, wherever you're joining from. And we're going to start in a few minutes. We're just waiting for more people to join in, and also a few other things, and then we get started. I see Bibi has her hand raised, all his hand raised. Bibi, do you wanna type your question, comment, or unmute and speak? Oh, there's Suzanne. Suzanne, we were wondering where you are. Good to see you.
Yes, I'm here, Ben.
Excellent.
Good day, Ben. Good day, Steve. Hello, everybody.
Hi, Alessandro. How are you?
Oh, feeling pretty good, thanks. And you?
Great, great. Thank you. Okay, for those who have just joined now, greetings and welcome. We're just waiting a few more minutes, and Professor Helen Rees, who is the NITAG chair, is going to make a welcome speech, and then we're going to get started. So hang on, we're going to get started soon. Thank you. Susie? Oh, great. Hi, Helen. How are you?
Be late joining. Just adjust this for the right thing. Yeah. So hi. Sorry and apologies. I see that there's quite a good turnout and a lot of participants en route. So do you want to start off, Benjamin, by saying a few words and then I'll come in?
Yes, and thanks, Helen, for making time to be with us in this webinar, and greetings to you all again. Alana, if you could just project the number of people who have registered and who are attending. So just a brief few words. So this is a webinar that is organized by WHO, NISH, and also partners. And although, I mean, most of you know,
Est-ce que vous pouvez aller là-bas? C'est en français,
on
puisque le son
Mpox
n'arrive pas bien ici.
on the
À
continent.
côté de Dr. Audrey.
And
Il se met où?
although there are
Ici ou
many
là-bas?
information channels and sources that are flowing through, we thought that it was useful for us to organize a webinar that focus specifically on the work of NITAGs and their role in supporting the response to this outbreak. And so this is a webinar that is purely designed with the needs of NITAGs in mind. And with those few words, Helen, I will hand over to you to welcome the participant, and then we can get started with the agenda. Thank you so much.
Thank you very much. And by way of an apology for being a couple of minutes late, I've actually just left our NITAG meeting here in South Africa, where we also discussed the Mpox outbreak. This is obviously an incredibly important issue at the moment for the region. Last time I looked, and the numbers vary, we have 16 countries affected. As you all know, we've always had clade 1 and clade 2, but what we've seen is an evolution of clade 2b from West Africa, causing the 2022 large outbreak that occurred globally in over 116 countries. But now we have a spreading outbreak, with the DRC being at the epicenter, but Burundi is also being affected, Nigeria. We have a spreading outbreak in our region with a new clade 1b, which in addition to being spread through household spread, is also we've now observed heterosexual spread as well. And the clade 2b is also present in the region, in South Africa, for example, but also I think in Cameroon and a couple of other countries. And that seems to be an MSM and bisexually spread virus, predominantly, not exclusively. So against that background, clearly WHO, the Afro region, WHO HQ, and Africa CDC are all playing incredibly important roles together in responding to this. And we'll hear more about that in today's presentation. So with that, I'm going to hand over to Rina Doshi from the African office of WHO, and she's going to give us a full outline of where we are with the outbreak. Over to you, Rina.
Okay.
Thanks,
Hopefully you
Rina. Thanks,
see my
Helen.
screen.
Yes, we can see your screen, Rina.
Okay, great.
Just before you get started, Rina, thanks, Helen. Just to mention to the participant that we do have interpretation option. So if you go down on the globe icon for the interpretation, we do have the Portuguese, French, and English channel. So please select the channel of your choice. And if you've got comment, questions, type on the Q&A chat, and then we're going to collate them, project it on a slide, and then we're going to have panelists discuss these questions and comment with you. Thank you. Back to you, Rina.
Hi, everybody, and thanks for that. My name is Rina Doshi, and I am the focal point for vaccination in the Emergency Preparedness and Response Cluster at WHO Afro. And I'm just going to talk a little bit about the current epidemiology and what's changed very briefly, and then get into how we're using Mpox vaccines in the region, some of the knowledge gaps, and talk about what countries can do next. And I think I just have about 10 minutes, so I'm going to try to go fairly quickly. So this is the African region epi curve, the confirmed cases as of the 25th of August. So as you can see, this dates back to 2022. You can see that we're seeing a substantial increase in cases since November of last year. The majority, about 90%, are coming from the DRC. So as of right now, the total number of cases is just under 8,000. And these are confirmed cases. So larger number of suspect cases. The total number confirmed deaths as of August 25th is 54. So the case fatality rate is 7%. And I just want to make a comment on that, that data is a bit skewed in that, the number of cases, the confirmed cases don't necessarily add up with the suspect cases, and that CFR is slightly off. Now, total confirmed cases and deaths from January 1st, that is 2024 to August 25th, is 5,000. So you can see that substantial number of cases are occurring in the last couple of months. And you can see the countries that are affected. Again, DRC is representing the largest number of cases. Okay, so African countries actively affected. So I want to say actively because these are where we're seeing current cases. So some are newly affected or re-effective, as Helen alluded to just a few minutes ago. So Burundi, Rwanda, Uganda, Kenya, Cote d'Ivoire, Liberia, Gabon, Republic of Congo, Nigeria, Central African Republic, and South Africa. And suspect cases are being investigated in other countries. Most of the countries that are affected, newly affected right now, have confirmed clade 1b, the new variant circulating. So moving on to clade 1b, so we know that this emerged in 2023 and has been spreading through sustained human-to-human transmission in Eastern DRC since probably September 2023 in the absence of zoonotic exposure. It's been detected in 6 other countries, in Burundi, Rwanda, Kenya, Uganda, and even Sweden and Thailand, but also linked to travel history to the region. The current estimated case fatality ratio is 0.7, with the largest number coming from the DRC. All Mpox types of transmission still continue to occur, but want to point out, as Prof. Helen mentioned again, that sexual contact has really amplified transmission quickly in certain networks and areas, particularly in the eastern part of DRC. Drivers of transmission include human-to-human, close contact, sexual contact, as well as other Mpox modes of transmission. No deaths have been reported so far outside of DRC in regards to clade 1b. Now, touching on the complexities associated with all of this, we still have an unknown animal reservoir. There are suspected animals, but still not confirmed, unclear. There's an unclear contribution of zoonotic and human-to-human transmission in African settings. And we're really seeing that in DRC with the 2 distinct outbreaks, which I'm not going to get into too much today. There's different distribution of MPX V clades, so the virus, clades and subclades. So, as mentioned previously, we're seeing circulation of clade 2 in some countries, but then also circulation of clade 1b, likely imported from DRC throughout the region. Unfortunately, we have low sequencing available to monitor emerging strains. And again, as mentioned previously, it's really unclear the human-to-human transmission dynamics in different settings because we're seeing such distinct outbreaks. This leads to the different age groups that we're seeing and demographics that are affected in different geographical areas, making the comparison of severity and outcomes complex to interpret. In the northwestern part of DRC, we're seeing children largely affected, but in the eastern part of the country, we're seeing individuals over the age of 18 largely affected. There are multiple concurrent outbreaks with different characteristics, and this makes things challenging. And affected areas in the eastern part of DRC are also affected by conflict and insecurity, which hinder surveillance and response activities, as we've seen with the large North Kivu Ebola outbreak. So I won't go into too much detail on this, but just wanted to touch on the standing recommendations that state parties are recommended to develop and implement national Mpox plans that build on WHO strategic and technical guidance. So vaccines and other countermeasures are included in the DG's standing recommendation on Mpox. And that was the last recommendation, that we work toward equitable access to safe, effective, and quality assured vaccines, tests, and treatment for Mpox. And the main thing I wanted to mention, and these were extended for another year just this month. Vaccines and immunization are a critical component of the overall strategic framework for Mpox control. So vaccines are part of community protection, where we raise awareness and empower communities to adopt these protective measures, such as vaccines, and then also in the countermeasures, where we improve access to effective diagnostics, vaccines, and therapeutics. All of these with the goal to stop Mpox. So I know these will be discussed in a little bit in more detail with the SAGE recommendations, but there are 2 vaccine products that we're discussing for use in the region that are currently licensed across various countries for use. They are not pre-qualified at this time, and I'll talk about what that means in a second. So the 2 vaccines are the MVA-BN, which is licensed in Canada, EU, US, UK, and Switzerland. And it's 2 doses, 4 weeks apart. And then the second vaccine is the LC16, the minimally replicating. It's a 3rd generation vaccine, a single dose regimen, only licensed in Japan, and is also planned to be rolled out in DRC. So where are we in the African region? So vaccines are not currently pre-qualified or have emergency use listing, and there's no global stockpile. WHO DG did trigger the process for EUL for Mpox vaccines, and that's going to accelerate vaccine access in the African region. That happened just 2 weeks ago. The EUL will also enable partners, including Gavi and UNICEF, to procure vaccines for distribution. So this is really one of the biggest things. And then Gavi did announce a couple of months back, after their board meeting, that they would establish a global stockpile of Mpox vaccines. So what this will likely look like, and will not be available for quite some time, will be similar to existing stockpiles for cholera, for Ebola, meningitis, or yellow fever. So this stockpile is pending the availability of the WHO EUL, which will hopefully occur in the next month or so. Just wanted to touch on some of the evidence gaps that remain on the use of Mpox vaccines, because I think this is important for how the region will roll out vaccination. MVA-BN was used extensively during the global outbreak in the US and the EU and the UK. However, there are evidence gaps that remain in terms of safety during pregnancy and breastfeeding. Also in children, it was used under emergency use authorization in some countries for under 18. Also, this is important for the Japanese vaccine, the LC16 vaccine, which is approved already in Japan for children. But of course, more safety and efficacy data is needed. In terms of immunogenicity and effectiveness, we collected a lot of data during the global outbreak on MVA-BN. However, there is still needs to look at the vaccine effectiveness over time, whether there's a need for a booster, and also in specific subpopulations. And just in general, you know, I mentioned some of the gaps that we have in terms of understanding Mpox epidemiology. And these are really critical gaps that need to be addressed as we think about the entire response, which includes vaccines. Just to mention that there are studies that are ongoing to close some of these evidence gaps. So cluster randomization phase 3 vaccination trial in DRC is planned for LC16. There is also a randomized control trial to assess the efficacy of LC16 in HIV, in an HIV positive population in Colombia. Of course, additional studies like this are needed in the African region. And I just wanted to highlight a few, and more are planned. Finally, you know, I wanted to touch on some of the, well, not finally, but I do want to touch on some of the regulatory pathways that exist. So as I already mentioned, the EUL pathway is in progress. Of course, as I mentioned, there are large data gaps. And so the use of the vaccines under research protocols or randomized control trials would add to the body of evidence needed. And then we are supporting countries at WHO through AVRF and through other stringent national regulatory authorities to approve the use of Mpox vaccines in their countries. Countries right now can access available Mpox products, of course, through direct procurement, but this is quite expensive. And then also right now with countries, as maybe folks saw the news that yesterday, the first doses of vaccine arrived on the continent in Nigeria outside of research. 10,000 doses were donated from USG, and other donations are underway for DRC in the coming weeks. And those can be negotiated. And, you know, right now we're also supporting that as well while we wait for the regulatory processes. Finally, I want to touch on what countries should do if they want to use Mpox vaccines. So, you know, this is a great step as part of discussing with the national immunization technical advisory groups. Really key is getting those recommendations. We've been supporting countries to do so. Also, to begin the regulatory approval for bringing new vaccines into country. Yes, the EUL will facilitate this, but in the meantime, you know, discussing with national regulatory authorities and the ethics review committee if necessary. And then also countries really should consider, you know, research protocols as a way to incorporate vaccination into the response to close some of these key knowledge gaps that we still need. And as I mentioned previously, you know, the African Vaccine Regulatory Forum, so AVRF platform in WHO is being used to facilitate authorization of vaccines. They just held a virtual joint review with various countries. And I will stop there.
Thank you very much. That's very rich in information, very helpful. Thanks, Rena. We'll come back to you, but I think we'll go straight on to Judith van Holten, who's going to present the SAGE recommendations, and then we'll have a joint Q&A. So Judith, are you with us?
Yes. Can you see the screen? Wait, I'll just...
We can, yes, it's not on presenter.
No, so is it now?
Yes, now it is. Go ahead, please. Thanks.
Okay. Okay, thanks very much. So my name is Judith van Holten, and I work with the SAGE Secretariat at WHO HQ. And yeah, thanks very much for inviting me. And I will present on the WHO Mpox vaccine recommendations. So first, a little bit of background or context to the Mpox vaccine position paper with the recommendations that was actually published last week. So first, in response to the global Mpox outbreak that began in 2022, there was first interim guidance on Mpox vaccines and immunization endorsed by SAGE and published in November 2022. And since then, a lot of additional epidemiological data has been obtained, especially from the African setting, and also new information has become available regarding the safety and the vaccine effectiveness of MVABN and a little bit on LC16. And SAGE considered all this new information at the SAGE meeting in March this year. And this led to the updated Mpox vaccine and immunization recommendations. And these updated Mpox vaccine recommendations are now published, as I just mentioned, in a position paper. And this position paper combines the SAGE-endorsed smallpox vaccine recommendations, which were developed in October 2023, with the Mpox recommendations from March 2024. So it's more or less an orthopox position paper. And I put the link here in the slide, so you can access it. And so now, before I go into the recommendations, I'd just like to remind you that there are currently 3 vaccines licensed for the prevention of Mpox, just as Rina just mentioned before. So which is MVABN, which is a third generation non-replicating vaccine. Then we have LC16, which is also a third generation vaccine, but this is minimally replicating. And then there's ACAM2000, which is a second generation vaccine, which is a replicating vaccine. And also to mention that ACAM2000 has not been used during the global outbreak that started in 2022. So now over to the recommendations. So these are, just to keep in mind that these are global recommendations, but they were very much made also with the African setting in mind. So there are recommendations in the position paper for preventive use of vaccines and also for use in outbreak settings. And I will focus here on the outbreak setting recommendations. So first, vaccination is recommended for persons at high risk of exposure to Mpox in an outbreak. Now, the identification of populations at risk of exposure is limited in some settings by currently available epidemiological data. And this is particularly the case for communities affected by zoonotic transmission. In studies involving men who have sex with men, pre-exposure vaccination with 1 or 2 doses of smallpox or Mpox vaccine was demonstrated to be effective against Mpox. But however, effectiveness of post-exposure vaccination is less certain, which could be linked to the predominantly sexual mode of transmission in the available studies. Now, to allow for the greatest flexibility with respect to local risk assessment, varied modes of transmission and response options, populations to consider for vaccination may include, and then we have 4 kind of different groups of populations based on local epidemiology, members of a geographically defined area or community. That could, for example, be a village, and this also includes children, as long as they have a documented high risk of exposure to Mpox. And then other group is sex workers, gay, bisexual, or other men who have sex with men with multiple sexual partners, or other individuals with multiple casual sexual partners. Then health workers at risk of repeated exposure, clinical laboratory and healthcare personnel performing diagnostic testing for Mpox or providing care, and outbreak response team members as designated by national public health authorities. And the last group we identified as contacts of persons with Mpox, and then they should be vaccinated ideally within 4 days of first exposure. And these contacts, they may include also children, others in the household, or congregate settings, such as people in prisons, schools, health facilities, or residential facilities. Okay, so now I over to the choice of vaccines. And here WHO recommends that for immunocompetent, non-pregnant individuals, so non-replicating vaccine MVABN, minimally replicating vaccine L16, replicating cell culture derived vaccinia-based vaccines such as ACAM2000 or equivalent vaccines that meet WHO standards for quality are appropriate for use. And so this is really for immunocompetent, non-pregnant individuals. Then there are also recommendations on vaccine choice for special populations. And I will start with the infants, children and adolescents. So for infants, children, and adolescents, where consideration is given to vaccination, non-replicating, so MVABN, or minimally replicating LZ16 vaccines may be used. Now, LZ16 is approved for use in children in Japan, as Rina mentioned, but however, you have to realize that LZ16 is contraindicated in pregnancy and in immunocompromised children and adolescents, including in uncontrolled advanced HIV. So in these cases, you should not use LZ16. Now, while MVABN is currently not licensed for persons under 18 years old, this vaccine may be used in infants, children, and adolescents when the benefits of vaccination outweigh the potential risks in the context of an outbreak. And then but when it's used like that, the use of MVABN in children constitutes an off-label product use. Now, replicating vaccines such as ACAM2000 should not be used in infants. And then WHO also recommends further collection of data on vaccine safety and effectiveness for these populations. And just to mention that even though MVABN is not licensed for use in children under 18, there is some data available on its use in this population. And so far, there doesn't seem to be any safety concerns, but obviously more data is needed here. Then the next special population is pregnancy. So during pregnancies, where consideration is given to vaccination, non-replicating vaccine MVABN should be used, and replicating vaccines such as ACAM2000 and minimally replicating vaccine L16 should not be used in pregnancy. And again, administration of MVABN in pregnancy constitutes also an off-label use. Then for immunocompromised individuals for whom replicating such as ACAM2000 or minimally replicating LZ16 vaccine is contraindicated, which it is, a non-replicating vaccine MVABN should be used. So likewise, for individuals for whom there are warnings or precautions because of immunosuppressive therapies or proliferative skin conditions, such as atopic dermatitis, non-replicating MVABN vaccine should be used. And then there's, so these were the recommendations on the choice of vaccine, but then we also have, there was also a recommendation made on what can be done when there is limited vaccine supply. And here we say, WHO says that based on the risk profile and the available vaccine data, WHO recommends off-label use of a single dose or intradermal fractional dosing of MVABN in supply-constrained outbreak situations. And fractional dosing is 1/5 of a regular dose administered intradermally, and this was also used in the beginning of the 2022 global outbreak when there was still limited vaccine available. But again, here WHO emphasizes the need to collect further data on vaccine safety and effectiveness in these circumstances. And then the last recommendation that I would like to present here is on persons who have been vaccinated previously And here we say that the duration of protection of vaccinia-based Mpox vaccines, which are all the vaccines, is not fully characterized and may vary between vaccine products. WHO recommends that individuals who are eligible for vaccination should be vaccinated, irrespective of documented previous smallpox vaccination and or visible smallpox vaccine scar. And then for individuals previously vaccinated with Mpox vaccines, an individual benefit risk assessment should be done. That was my last slide. And as I said, these can all be found in the position paper that was published last week.
Thank you very much. So let me open this up to the Q&A. I'm not sure if there are a list of questions here. I'm not sure if we've had a chance yet to put them into a slide, but let's go through them. Are you able to see them, both of you, Judith and Rena? If we've had a chance, Benjamin, to put them into a slide, that's even better. Otherwise, we can go through them in the Q&A list.
Yes, Helen, thanks. Alana or Salim, if you've collated the comment questions, please project as we carry on. Thank you.
Let's just give them a moment. So Gerald Masinzo, what do we know regarding the orthopox vac, a fourth generation vaccine from the Russian Federation? Is there an effort to include it into the Gavi WHO initiative to increase vaccine availability in the African region? I'm not sure who would be best to place to answer that. Judith, perhaps?
Yeah, I can say a little bit about that. I may not be the best person to answer, but this is a vaccine that was licensed in the Russian Federation. But as far as I know, it is not being manufactured yet. So it's not a vaccine that is available, and it's also it would not be available for markets outside of the Russian Federation. But that is as far as I know. There might be new information on this that I'm not aware of. We can't hear you, Helen.
Apologies. From Nisejo Kwate, can we begin regulatory approval process even if we do not have cases yet, just so that we can easily order vaccines whenever we need them? Now, not sure who can answer that best. Rena?
Yeah, I can start. So yes, that's one of the things that we're recommending, is that countries speak with their national regulatory authorities and the ethics review committees as well, get a NITAG recommendation to start the process as regulatory preparedness, essentially, right? So that when vaccines are available, countries are ready. Now, the EUL should alleviate some of the stress, but in the meantime, while we are waiting, these are things that countries can do, and these are things that, you know, we have been supporting countries to do.
Can you give more information about that? Because, you know, for a regulator, what they need is a dossier. Even for an emergency use, they need access to the dossier. Where does a regulator go to get a dossier other than the applicant? Because the applicant would have to give permission, for example, to the EMA to share the dossier, or to WHO. So how does that work?
Oh, I don't know if CD wanted to respond to that. I see.
Yeah.
Oh yes, go ahead, Sidi, please.
Yeah.
Thank you.
Thanks, Chair. For the countries interesting to join the joint review, so there is activity joint review organized by AVRF next week. So I will drop the mail to Kwasi. So if you are interested, I will put his mail in the chat. and you can join him if the country is ready to join this the joint review. Okay, thanks.
I think that would be hugely helpful if everyone on this call could have the information about the joint review through AVREF, because I do know that a regulator can only do what they're given. So that would be hugely helpful if that could be done. Then the next one, receiving the slides, I think we can say that's okay. Is that, Benjamin? Everyone can receive the slides. Is that possible?
Yes, that will be possible soonest after this webinar.
Thanks. Then Gerald Masinzo, lorry drivers have been documented to be indexed cases in some of the countries with new introductions of Mpox. Is there a strategy for ensuring mandatory vaccination at ports of entry as there is for yellow fever at the moment? Who'd like to take that one first? Rena?
So is there a strategy for ensuring mandatory vaccination at ports? So not at this time, no. We currently don't even have supply to vaccinate in the current outbreaks. As supply changes, recommendations could change, but at this time, there's no recommendation for any kind of mandatory vaccination, and probably won't be anytime soon.
Thanks. And just to add to that, I think you're all aware that under the international health regulations, the public health emergency of international concern was announced. And when those are announced, a set of temporary recommendations are issued. And the temporary recommendations can indeed make strong recommendations about immunization at borders. And if you look at the polio outbreaks at the moment, for example, in Afghanistan and Pakistan, where wild polio is still circulating, there is a recommendation in the temporary recommendations of immunization at borders, which both countries are doing. But that for the Mpox case at the moment, the IHR recommendations have not included mandatory vaccination. But under IHR, it can be an option under certain circumstances. But as Rena said, at the moment, we don't have a vaccine. And Judith, do come in if you want to add anything. Just shout. I'll try and alternate between the two of you. Okay, right. So then Fabrizio Giovanni Vaccaro. Oop, lost you. Is there any effectiveness safety evidence for Clade 1B? Very good question. What are the different costs of MVABN, LC16 and the ACAM 2000? Do you want to try that, Judith, on the first one?
Yes. So the data that we currently have available on the vaccine effectiveness, it comes from MVABN, and it's all studies that were done during the global outbreak that started in 2022. So these are all studies done on clade 2B. However, we anticipate that MVABN and other vaccinia-based vaccines will also demonstrate effectiveness against clade 1 due to the cross protection between all those orthopox viruses, because originally these vaccines were developed for smallpox, against smallpox, but they also work against Mpox. So, but we definitely, it would definitely be good to have, of course, confirmation of this through studies. But we do anticipate that they would, that they do work, and it would be effective. What the different costs are, I don't think that is clear. I don't think we know exactly what the costs are of these different vaccines. I don't think we can say anything about this, but maybe Rina, you would know more. But as far as I know, I don't think we know exactly what the costs are.
Rina?
Yeah, so I know that MVABN is quite expensive. I think it's about $100 a dose at this point in time, and it's a 2-dose regimen, so quite expensive. And there will likely be negotiations associated with that. LC16 is not commercially available at this time. It's only licensed in Japan, and they have a stockpile, and they've kindly offered to share doses. with DRC. So in terms of cost in purchasing that, that's also unclear. In ACAM 2000 at this stage, I'm not sure of the cost, but it's not really being considered at this time for use in the outbreak. It's only licensed in the US right now and wasn't really used during the global outbreak either due to some safety concerns.
Thanks. And then we'll go straight to Patricia Rasoloma Manana. Is there a rapid test and how much is the vaccine?
About the diagnostics, I'm not the best person to ask. So maybe Rina, you know something about this.
I'm also not an expert on diagnostics. I do not believe there's a rapid test. I believe that, and also in terms of diagnostics, I think diagnostics have been one of the larger challenges. And this is something that, we're trying to address. But I don't know if there's anybody on the line that is a lab expert that could better address that.
I think the answer is it is lab-based. It's PCR, gene expert. But I agree with you that there is no rapid test at the moment. And of course, in hard to reach areas such as in the DRC, that makes it very difficult because of shipping of samples. So it's an important point, and it's one we should keep an eye on. Then I've got Georgina Joachim. Could you please clarify the use of MVABN in children under 18 years? I see mixed recommendations in the presentation. So could you clarify that, Judith?
Yes. No. So just to say that WHO recommends that if the vaccine if you would like to vaccine children, that there are two vaccines that can be used, and it is MVABN and LC16. But they both have a bit of a context. So LC16 is licensed in Japan. So it can be used in children. However, it is contraindicated in pregnancy and in immunocompromised persons. So you have to keep that in mind. Then MVABN is only licensed for persons 18 years and older. So it's not, so if you use MVABN in persons under 18 years of age, it's an off-label use. However, during the outbreak, the outbreak that started in 2022, there are several studies that have included children. And there's also were two studies, one in the UK and one in the US. And there's a surveillance study that was done in the US. And there were no safety concerns observed there. It's also, MVABN is also used as a viral vector for the Ebola virus vaccine. And this vaccine is licensed by the EMA for children or infants 1 year and older. And this has been studied in about like 50,000 children. So there is data on MVABN, and so far we see that it seems to be safe. However, it is not licensed, so that's why it is also it would be an off-label use. I hope that's clear.
But often NITAGs do make off-label use recommendations, so that would not be unusual, especially in an emergency situation. And other vaccines, for example, with Ebola, were also used in an emergency situation for groups where there was limited data. So the use of Mpox vaccines as post-exposure prophylaxis from Gerald Masinzo. And then we won't be able to get through all the questions within this timeline, but we will, the request is that we will send you written answers. I will then go to I've got two hands up, and I'll go to those two colleagues, Mohammed and Babu. But if we could start with the post-exposure, good question for contacts.
Yes. Yeah. So the use, so post-exposure prophylaxis, that means indeed the vaccination of contacts of a person diagnosed with Mpox, and that is something that we also have in our recommendations that that could be considered for vaccination use, especially. We have seen that in the data that the vaccine effectiveness seems to be rather low when using this post-exposure, but that might have to do with studies that were done in men who have sex with men, which were the transmission mode was mainly sexual transmission, and it was also difficult to define control groups, and you need to be quite fast, probably within 4 days of exposure. However, we think it would still be useful in the especially also in the African settings, for example, for household contacts and the others that I mentioned in the recommendation. Yeah, this is definitely something to consider in the vaccination strategy.
Yes, but as you say, the sooner it's offered, the better, because the use of the vaccines in a preventive manner is more effective. I'm just going to go to Mohammed first. Mohammed, if you could briefly state your question. We might have, I don't know if we've lost Mohammed. So let's go to Babu. Are you able? Oh, I think that because you're not on the panel, you can't speak. That's the problem. So if I could ask both of you to put your question into the Q&A boxes, and then colleagues will send answers to any that we don't get through during the session. That's why you can't speak. Sorry, I wasn't thinking. Thank you very much. Yes, yes. Yeah,
we'll
go
try
ahead.
to get our technical team to unmute them, and they have the right to speak.
They are unmuted, or they have the ability to unmute at the moment.
Oh, they do. Okay,
Yes.
thank you. So Mohammed, I'll try again. Are you able to unmute? I'm not getting any luck there. Mohammed, so if you could put your Q&A into the Q&A, put your comments there. And Babu? No, we seem to be having a technical problem. So let's go back to I think because of time, we're on time at the moment, but if we can come back to some of these questions in the chat, we will. So in the meantime, we'll go to the next section, which is looking at the ongoing activities to support NITAGs. And Sidi will open it up, and it'll go Sidi, Stephen, Susan, and then Sidi at the end. And we'll just go straight through each of those presentations. And then again, we'll have Q&A at the end. So Sidi, over to you. Thank you.
Thanks, Chair. Do you see my screen?
Clearly, thank you.
Thanks. As the slide are in English, I will switch in French. Donc, merci beaucoup à tous les GTCV qui sont connectés pour suivre ce webinaire. Alors, dès la prise de décision par rapport à cette épidémie de Mpox, nous avons travaillé avec les partenaires qui appuient les groupes techniques consultatifs sur la vaccination à mettre en place quelques outils que les GTCV peuvent utiliser pour faire les recommandations. Alors, on va commencer d'abord par les quelques questions qui ont été identifiées au sein du groupe de travail. La première question politique que le GTCV peut recevoir, c'est est-ce que le pays recommande l'usage des vaccins Mpox dans la population à haut risque durant cette épidémie. Alors, comme vous le savez, à chaque fois, vous posez la question sous forme PICO avec la population, l'intervention, le comparateur, les résultats et aussi la question PICO de façon globale. Alors ici, nous avons identifié les populations à haut risque comme étant des populations qui sont en contact avec des cas dans la communauté, qui vivent dans la communauté avec des cas, comme je le disais, mais aussi d'autres populations telles que les chasseurs, ceux qui sont en contact avec des animaux sauvages, soit vivants ou morts. Ça, c'est un peu les personnes à haut risque qui ont été identifiées, mais aussi des personnes qui ont des contacts sexuels avec des partenaires multiples et aussi, il y a ce qu'on appelle les travailleurs de première ligne, tels que le personnel de santé, mais aussi des travailleurs qui sont au niveau des portes d'entrée, des frontières, l'aéroport ou des frontières terrestres. Donc, la question PICO que nous avons à proposer, c'est que chez les personnes à haut risque, est-ce que l'administration des vaccins contre le Mpox, quel que soit le vaccin, est-ce que c'est sûr et efficace pour réduire l'incidence des infections et de l'hospitalisation conduisant au décès. Donc, dans le bas de page, vous voyez un peu la définition qui a été proposée dans le position paper de l'OMS. Il y a une deuxième question de politique générale qui a été proposée, c'est que la question concerne est-ce que le pays recommande le vaccin contre les Mpox pour les travailleurs, les personnels de santé et les travailleurs de première ligne à haut risque d'être exposés durant cette épidémie. Donc là aussi, la question, la population a été, donc le personnel de santé et les personnels de première ligne ont été définis comme le personnel qui est exposé, qui a une exposition répétée avec soit en traitant les malades ou bien le personnel de santé qui travaille dans les laboratoires, mais aussi le personnel de soutien dans l'hôpital, exemple, ceux qui font le nettoyage, ça aussi, c'est des personnels à haut risque d'attraper la maladie s'ils sont exposés, donc s'ils sont en contact avec des cas probables. Alors là aussi, la question PICO donc, a été posée ici, que vous voyez. Et donc ça, on peut dire que en fait, ça, c'est des propositions que nous, en tant que groupe de travail, avons identifiées comme étant probables sur lesquelles les GTCV peuvent travailler et faire une recommandation. Et sur la base de ça, nous avons proposé un tableau des données probantes que Steve Adler va présenter tout à l'heure. Mais quand même, ce qui est important, c'est qu'il y a des considérations que vous devez prendre en compte. La première chose, c'est l'identification des groupes à risque et la priorisation. Ça, c'est comme on l'a fait durant la COVID. Les vaccins, la disponibilité des vaccins, elle est limitée, mais aussi le CEJ ne recommande pas une vaccination, des campagnes de vaccination de masse. Donc, il faudrait identifier les groupes à risque pour pouvoir aussi prioriser parmi ces groupes à risque-là, vu le nombre limité de vaccins disponibles dans les pays. La deuxième chose, pour pouvoir prioriser et identifier les groupes à risque, il faudrait faire une analyse épidémiologique des données que vous avez à votre disposition, en faisant une stratification par âge, par profession, mais aussi les contacts, le type de contact, etc. Donc ça, c'est réellement important, mais aussi les clades qui sont en circulation dans le pays. Nous avons aussi, par rapport à l'efficacité et le profil de sécurité du vaccin que vous allez proposer dans votre recommandation, ça veut dire que dans la recommandation, il faudrait réellement faire des recommandations subsidiaires par rapport aux données de surveillance qui seront collectées dans le pays pour pouvoir un jour mettre à jour votre recommandation. Ça, c'est réellement quelque chose sur lequel vous devez insister dans vos recommandations. Il y a d'autres considérations aussi. Et je reviens sur les opérations de GTCV. Là, comme vous l'avez fait avec la pandémie COVID, il faudrait élargir vos groupes de travail en faisant vraiment une approche One Health pour pouvoir faire des recommandations qui prennent en compte tous les domaines d'expertise que vous avez dans le pays. Donc, vous pouvez coopter des vétérinaires, vous pouvez coopter des environnementalistes, mais aussi, il se posera certainement des questions d'éthique par rapport à l'usage off-label des produits, mais aussi à l'usage en urgence. Donc, dans le contexte d'urgence, ça veut dire qu'il y a des questions éthiques sur lesquelles vous devez vous pencher aussi. Donc, il est important aussi de pouvoir travailler avec l'organe de régulation au sein du ministère de la Santé ou au sein du gouvernement, mais aussi le comité des MAPI aussi doit être convié dans vos groupes de travail pour pouvoir faire vos recommandations. L'autre chose, c'est qu'il y a une grosse expérience qui a été tirée de la pandémie COVID. Les NITAG ont pu faire à temps des recommandations, ont pu raccourcir les délais pour faire ces recommandations-là, mais aussi ont pu appuyer les ministères de la Santé dans le plaidoyer, dans la formation des agents de santé, dans le briefing au niveau des médias. Donc, là aussi, c'est vraiment une occasion pour les GTCV de pouvoir appuyer ces activités-là au sein du ministère de la Santé. Et certainement, on aura de nouvelles évidences dans les semaines à venir, dans les mois à venir. Ça veut dire que si vous faites une recommandation, il faudrait essayer aussi de voir les évidences qui viennent au jour le jour et pouvoir adapter et mettre à jour ces recommandations. Donc, c'était ça que je voulais vous présenter. La suite sera présentée par Steve Adler par rapport au tableau des données probantes. Merci, Madame la Présidente. Thank you, Chair.
Thank you very
Over to
much,
you.
Sidi. Stephen.
Thank you, Sidi and all, and let me see if I can share my, let's see, I think it's this one. Okay, can you see my slides?
We can, but they're not in presenter mode. But if you're having trouble getting them to presenter mode, don't worry, because we can see them well enough.
Oh, it's yeah, they're in a presenter mode. Well,
Stephen,
yeah.
if you just click there at the top left where it says display
Yes.
settings,
Yes.
Oh, which one?
the top left, display settings.
No,
Above that, to the
Not-
right.
right,
There we
yeah.
go. Click that. And then just say swap present to view as slideshow.
It doesn't seem to be doing anything.
It seems to be red. It doesn't look like it's working. Don't worry.
Do-
We can see well enough, so please go ahead. Don't worry.
I apologize. You have to. Again, I'm Stephen Hadler. I work for the Task Force for Global Health. But we've collaborated very closely with Citi and WHO Afro in doing NITAG strengthening, specifically focused on evidence to recommendations process. And this is to follow up Citi's presentation on what resources we've developed to try to support NITAGs in developing recommendations using this process. So I'll talk briefly about developing the evidence tables, PICO-specific evidence tables for Mpox, focusing on all 7 criteria domains. I'll just show 2 of them, but all of them will be made available to you after the webinar. Note these are examples which were developed in consultation with WHO and US CDC experts. I'll talk about 2 domains briefly and show several slides just of tabulated information on the vaccines available based on the WHO SAGE recommendations, and a sample worksheet for considering risk groups to vaccinate. Again, emphasizing all these will be made available. They will be updated as appropriate. And so just to remind anyone who's worked with evidence to recommendations, we work with 7 domains. I won't go into details now about all of them, but again, they are all included in the materials we have. And just an example of how the criteria tables work for domain 1, this shows the problem, which is one of the key criteria in this case, and it has several elements: the burden of disease, clinical characteristics, use and costs of healthcare, alternative prevention and control measures, remembering that their vaccine is one of the mitigation tools, and then regional and international considerations. And each of these have several generic categories of evidence which could apply to any vaccine, but which need to be adapted to each vaccine. And so as you look at how the tables then get developed, this shows an example for Mpox of a table to be developed, but the PICO question is one of the ones that the city just showed you. In persons at high risk of Mpox in community during an Mpox outbreak, what is the evidence the vaccine is safe and can reduce incidence of infection, hospitalization, and death? And what you'll see are not only the generic elements and categories of evidence, but then place where information can be entered on the PICO-specific evidence to collect for Mpox vaccine. For this question, what is the priority? Is this critical information that you must have or important information? And what are some sources of evidence, or what are these sources of evidence that you'd like to have? I'm going to show you now examples of what we have developed. And again, these are intended to be tools for your use, to be modified as you see fit. This shows the first 2 elements for the disease, for the problem domain, the burden of disease. And what you'll see is incidence, morbidity, mortality, of course, the incidence, hospitalizations, and deaths due to Mpox before, but particularly during the outbreak, age-specific incidence of these conditions, but particularly important are who are the risk groups. First, risk groups for severe disease, such as immunocompromised, pregnant women, young children, but also persons at risk during outbreaks. And this lists a number of the ones that both Judith and Citi have mentioned already. And then it goes on down to what is the Mpox virus clade, and so on. Let me just go back one. Obviously, the priority for this is critical. You may wish to change priority, but the key sources of evidence are going to be surveillance in country, perhaps supplemented by Afro-CDC and WHO Afro on information from neighboring countries that may be relevant. You'll hear a bit about doing rapid reviews in a few moments, but particularly for persons at risk during outbreaks, this needs to be defined, within the country, and this surveillance and your system for identifying cases is critical. And this then shows information for the other elements in this domain. Again, we don't have time to go over this, but all of this will be provided to you, and we are happy to answer questions and to modify this as it may best suit you. This shows the building out of the criteria table for the benefits and harms. First, the vaccine characteristics, and you've heard much about this already. And the second about safety considerations. Again, these have been covered and are well defined in the WHO position paper. And then efficacy and effectiveness, including the several elements, what are the determinants of immune response and so on, based on information that's available in WHO. We've also developed several tables just showing general information for each of the three vaccines that might be used. This table is actually one that that Rena showed earlier, or adapted from that, showing the general information about the vaccines. This one shows more information about the safety and efficacy, noting the adverse reactions, which are the minor ones which are common for all the vaccines, but the serious adverse reactions are extremely rare and really only documented well for the ACAM 2000 with myocarditis, and the information available about the efficacy and or immunogenicity. And finally, one about, again, just summarizing the choice of vaccines for different at-risk populations, noting, again, for adults that are immunocompetent, any of the vaccines could be used, but for infants or children, only the MVA-BN and LC16, and for pregnant women, immunocompromised, and others, such as allergic dermatitis, just the MVA-BN. And finally, this is a draft tool that might help NITAGs begin to compile information about what are the risk groups that they want to consider. Just working across the table, you can see it defines outbreak situation, non-outbreak, and as Judith said, laboratory workers and outbreak response team. This would be before the outbreak is even happening, but then prevention during the outbreak, and a number of the risk groups listed here, or potential risk groups. The notes suggest a little bit more information about these, but the key information the country needs to begin to compile and put in here is the geographic considerations, if it's not widespread and limited to some areas, what's the estimated risk for each of these groups, or the comparative risk in terms of how you might begin to prioritize who you would vaccinate, the risk of complications, again, noting that young children, immunocompromised, and pregnant women have higher risks of complications. And to just point out the vaccine strategy, that at least for contacts of cases, it may be post-exposure, which is less effective and should be done within a short period of time of exposure. So this is intended as a tool. It's very much a work in progress, and we very much appreciate any feedback on this. So yeah, and we're going to move on to other presentations, but again, we'll be happy to answer questions and to try to modify these as will best support your NITAGs. Thank you.
Stephen, thank you very much. We'll go straight on to Susan, who's going to talk about the library guide. Susan, thank you.
Good afternoon, everyone. I'm just trying to find my slides. I'm very sorry. Trying to find my presentation.
Don't worry. Why don't we go back to Sidi, go on to Sidi, and we can come back to you.
Sure.
Which is the EIDM support. Sidi, over to you. Sorry to jump on you. I hope you've got your slides.
I've got my slides now, but anyway.
Oh, you have. No, it's fine. If you've got your slides, better order. So Susan, go ahead. Thank you.
Okay. Can you see my screen?
Yes, we can. But I see you've got 21 slides. I don't think we'll have time to go through all of those.
No, I'm not talking about each slide. I'm just showing
Okay.
where to find it.
Lovely.
So,
Okay.
yeah. So, good afternoon, everyone. My name is Susanne Knoll. I'm a librarian or an information specialist for NISH. I'm talking about library guides, a library guide specifically for the Mpox. What are library guides? They are a content management and information sharing system, and they are very user-friendly, efficient electronic resources that can meet the information needs of our users, in our case, NITAG members. So what I have used to find literature, these are the three databases, mainly PubMed, EBSCOhost, and Google Scholar. I also use the PICO model to find literature, and P in my case is also the population, which I derive, which is in my case, all African countries, to be able to include all the literature that has been published of all the countries on Mpox. For the intervention, these terms were retrieved from PubMed, but for simplicity, we only used Mpox vaccines and Mpox. The C for comparison, we have got nothing to compare for at the moment. And my outcome, I used the word safety or efficacy or treatment or impact or reduction of disease or morbidity or mortality. So these are the keywords I used to be able to find those articles and papers of those databases I mentioned before. My result list, after I ran these searches, I found very literature, hardly any systematic reviews because it's such a new topic, and the result list showed mostly on Mpox only and not necessarily anything on the vaccine. So what is the message? We urgently need research information from all of you and your institutions so that we can learn from each other how to confront this disease. We plead with you to share and distribute experiences. So where do we find the library guide? Firstly, you have to go to the NISH website, www.health.uct.ac.za/NISH, and under Assets and Resources, you will be able to find several library guides, and the latest one will be the one on Mpox. This is what it looks like in general, and it is divided into tabs, and each tab covers a specific topic. Under the Home tab, for example, you will find the latest Mpox position paper, and the papers that were used for that position paper with its citations have been extracted from the position paper and made it available for you in the full text to read, should you want to have a narrower look at which literature was used to compile that position paper. Under the tab WHO NITAG Resource Center, you can find a dashboard with key figures and the systematic reviews that were created until now. It is only 5 or 6, but I'm sure as time goes on, there will be more systematic reviews. Under the tab Media News on the Mpox outbreak, you can find the latest media reports nationally and internationally on the Mpox outbreak, and those are usually newspaper reports. We are at the moment in the process of creating a rapid review on the Mpox. On the webinars, on Mpox, we will post all the webinars that will occur and the recordings of those which have occurred already. Sorry, this is the one with the webinars. Then the training resources, the WHO offers an introductory course for African outbreak context, Our World and Data. Here you can find explore data on Mpox, such as confirmed cases and deaths published also by the WHO. Mpox Global, these papers include general research about Mpox, such as Mpox vaccines, their effectiveness, their impact, safety, reduction in disease, morbidity and mortality, and immunogenicity. The following tabs contain articles about specific African countries on Mpox, such as the DRC, Cameroon, Nigeria, Central African Republic, and Sierra Leone. Those are the only countries I could find information on the impact. WHO and other gray literature. WHO has created many resources that are hugely informative and useful, such as this Mpox Outbreak Toolkit and relevant papers, documents, reports, manuscripts, which you can find here. And lastly, Elsevier, who have created a healthcare hub to help healthcare professionals navigate the current outbreak. Here you will find evidence-based clinical resources, including overviews, patient education, and drug monographs. I hope that this library guide will help you finding resources or lead you to more and better understanding of the Mpox outbreak. And that's all I have to say. Thank you very much.
Thank you very much. That's incredibly helpful. What a rich resource. And I'm sure there's other things on there beside Mpox that people would be interested in looking at. So thank you very much.
Yes.
Thanks, Suzanne. Thank you. And let's then go to Sidi again for the EIDM support. Thank you.
Thanks, Chair. So this is just to say that this is a work beginning. So we'll be waiting your feedback on that, and also if the NITAG needs support, kindly go to this website, which is hosted by the NITAG support hub, where you will find all this material, but also you will find the help desk. So in the help desk, you will fill your needs, technical assistant needs, and I will be receiving a copy of this request, as well the team from NISH, and we will be supporting you on that. In addition, you can also request support the working group on for the recommendation issuance. And lastly, we will be organizing a subsequent peer-to-peer recommendation note review. So we will be sharing with you a form. If the NITAG want to have twinning with another NITAG or peer learning, so you can fill in this form and send back to us, so we can support you accordingly. So this is what I wanted to say on that. Thanks.
Thank you very much. We'll open up for questions. There's something that we could put in the chat, which is a question for the link to the library guide website, and just questions for the links for people to go to. Thanks. So are there other questions? I'm going to go back up to the questions we've already got, some of which might not apply to the later set of presentations. There's one anonymous, which, if I've understood, I think could just be clarified. And Judith, I'll come to you. Or Rena, the availability of vaccines is not okay. I think we would all agree with that. But it seems countries must have the 3 vaccines in regard to the indications and contraindications to cover all the target populations. Judith, do you want to just tackle that? The countries don't need the 3 vaccines, nor will any country get the 3 vaccines unless they purchase them themselves. So could you just reply to that and just clarify how countries could use a vaccine? Very likely they would have, for example, the MVA.
No, they don't need the 3 vaccines. No, correct. Especially not ACAM 2000. ACAM 2000 has not been used so far in the response during the global outbreak. The vaccines the vaccine that's mainly been used is MVA-BN, and LC16 has been used in Japan a little bit, but both can be used. And it depends, I guess, also what is available, and there are some contraindications for the use of LC16, and in that case, you should use MVA-BN, but this is all described in the recommendations. Yeah.
Thanks. But an interesting point, and I think we should explore this, from Babu, saying that VaxPert from Germany is a rapid test for use at ports of entry, and it's recognized by the EU. And he's talking from, I think, from Mauritius. Is anyone familiar with VaxPert, and do we know which ports of entry are using it? We're certainly not using that in South Africa. We're giving information out, but we're not screening in any way like that. So I think that's well worth noting, and Rena, perhaps we could explore that and find out more about it and what Mauritius might be doing, if you know what VaxPert is, and then share that with everyone. Then there's a question: is there any evidence of transmission from humans back to animals? Rena?
Yes, I just put answer to that in the chat. We know that Mpox is zoonotic, and we do not at this time, and I think I mentioned this earlier, that we don't know the reservoir. It is an unknown reservoir at this time, and more information is needed on that. But we do know that there has been documented animal to human transmission, and so it is recommended that if, especially, and this has been seen a lot in Equator and DRC, and in other endemic areas. So it's important that if people do come in contact with an animal that appears to be sick or has a rash, that that they do not touch that animal.
I think it was the other way around. They're saying, is there any evidence of, I have to find it, going back from humans back into an animal reservoir?
Yes, sorry.
As we're seeing with H5N1
Yes.
in the US.
Yes. That has also been documented as well. So there is a recommendation that if you are sick, that you don't come in contact with your animals as well during the time that you're sick, just like with other humans. Apologies.
Thank you. Then I'm taking Celia Nalwada. Could you please confirm which manufacturers have submitted documents to WHO for an EUL?
Yeah, I can say that what I understand is that Bavarian Nordic has submitted documents, and there's also a talk with the manufacturer of LC16 to submit the documents.
So far, Bavarian Nordic. Do we have any sense, Judith or Rena, how long the EUL will take? I know that there was a PQ process in hand. Any idea how long the EUL will take?
I don't really know. I'm sure they're going to fast track it, but I don't know if you have better vision on that, Rena.
I had heard a couple of weeks to a month, but that's the most information that I've received as well. I think it depends on when things were submitted, and I know, as you mentioned, things had already been submitted by Bavarian Nordic. So hopefully we'll have some news in a month.
But it's not yet. This is from Elangeringa Kale saying, is it PQ'd yet? Which he thought he saw in the slide, but it's not PQ'd yet, if I'm correct.
No, it's not PQ'd, and there are no plans to pre-qualify it at this time. Right now, it's just the only plans are for EUL.
Thanks. And then Mary Beth Maritim is saying the persons with the highest risk for mortality are those who are immunocompromised, but the vaccines are contraindicated. Could you clarify that, either Rena or Judith?
Well, the vaccine is not contraindicated in immunocompromised. The MVABN is we say that if there's a need for vaccination in a person who is immunocompromised, they should use MVABN. They should not use ELSA16 or ACAM 2000. So there is an option.
And just to say, in South Africa, for that reason, we specifically have said, because we have a large number of people living with HIV, and so we specifically said we want the MVABN for that very reason. And then I'll just take the City. Could you translate? There's a question in French, and I've been reading it, and I decided I wouldn't have a go. Would you just translate for us? It's from Nuket Boitat Loretta from Loretta.
Loretta. Okay. I would like to know if the vaccine recommended by WHO are efficacious and induce immunity against the different clades of the virus. For example, the clades currently in Nigeria and in the Congo.
It's a good question. I think Judith answered it, but perhaps you could briefly outline the response again.
Yes. So yeah, again, so the data that we have from MVABN from the global outbreak is that was comes from effectiveness against clade 2B. And but we still think that, and it was just to say, it mentions the 2-dose effectiveness was 82%, found by a systematic review done. And but we do anticipate that that MVA and also the other vaccinia-based vaccines will demonstrate effectiveness against the other clades, such as clade 1. And that is due to the cross protection that is that's afforded between all these orthopox viruses. But there will still be a need for to confirm that with
more data. Yeah, there are lots of data gaps. We won't go into them, but there are many data gaps for all these vaccines. Well, if we have time, we'll come back. But I think we have to go on to the NITAG experience sharing on the issuance of vaccine recommendations, and we're going to David Mayer from Uganda. David, over to you. Do you have slides?
Yes, I do. I'm trying to share the slides. Yeah, there you go.
That's great. If you could go through them quite quickly, because we are running short on time. Thanks so much. Go ahead.
Thank you. So this is just our experience from Uganda, and just highlight a few things we've done. So the Uganda Mpox risk mapping and classification is sort of where the NITAG started from. And we've had various considerations and assumptions for risk categorization, looking at the proximity to epicenters, trade and regional transportation hubs, refugee host communities, and then looking at population movements, and then the districts providing social services. This map of Uganda really just shows the areas where we have risk categorized. As you know, the DRC is our neighbor, Uganda's neighbor, to the west, and so this is where we've sort of aligned that. We've had about 5 cases in the country, but so again, just looking at the issues around the porous border between DRC and Uganda, a couple of districts that do that as shown in the map. We've also had the issue of Ugandan army troops that are deployed in the eastern DRC, the long-distance truck drivers that ply the region. There's a whole trade route between DRC, Kenya, South Sudan, Rwanda, and we can't forget the immunosuppression population. Again, we only have about national suppression rates in HIV patients, viral load suppressed between 76 and 80%, which is below the recommended 95%. And so the process began with the Ministry of Health requesting the NITAG to advise on considering Mpox vaccines. So this was towards the end of July. We'd had 2 cases then in one of the districts close to the DRC, but currently we have about 5. 3 of the new confirmed cases haven't been in the border districts. So epidemiologically, they haven't been linked to the initial cases. And so we did have a full NITAG meeting 9th August, and an Mpox working group, which I chair, was then constituted. And we had our first meeting last week. Essentially, what we reviewed was the ETR framework. And just very quickly to the constitution, we have representation from medicine, public health, epidemiology, vaccinology, immunology. There's a couple of ex-official members as well from the expanded program on immunization. We have liaison members, WHO and UNC and UNICEF, and National Drug Authority and the Uganda Virus Research Institute have co-opted experts as part of that panel. And so there might be some variation in the picker questions that we considered, but we generally just looked at whether the country should use a vaccine against Mpox for the high-risk populations. We did consider WHO recommendations and alternative prevention control measures. And then for the population groups, again, the population at risk of severe disease outcomes, we plan to just have some more data on modeling for different scenarios to guide the selection of these high-risk groups. The vaccine products, I think we went through the ones that have currently been discussed here. And I think our recommendation was to sort of just have the possibility of using all of them, but depending obviously on availability and affordability, the ease of administration, so on and so forth. That's a process that's in the works. And what mode of introduction should be used? The EUL listing with emergency use listing with the research component is what we finally agreed on. We hope that we will be able to have some research as part of that emergency use listing. There are obviously social considerations looking at which populations are being targeted, the ethics, health communication. We do have the ability to leverage Ebola and COVID-19 response experiences. Obviously, also worth remembering that MSMs and sex work are illegal in Uganda, so that obviously changes things a bit. Then in terms of the next steps, we will continue to collect local epidemiology data, and then of course, continue to review the WHO SAGE recommendation reports. And we're glad that there's a library of information that is accessible. And we will then have the draft recommendation report for consideration by the full NITAG committee later this week. So thank you.
Thank you, that's very clear. And it also shows us the fact that every country is going to have quite different considerations. We now go to Abdon Mukale from the DRC NITAG. Abdon, are you with us?
Yes, Madam Chair, thank you. May I share with my screen, please?
Thank you. And do feel free to speak in whichever language you choose, because we've got interpretation.
I speak in French. Okay.
We can see the slide. Do you want to proceed? Oh.
Thank you so much, Madam Chair.
Oh. The line is very bad.
Yeah. Thank you so much.
The line is very bad. I wonder.
Good morning, good evening, good afternoon, everyone. Je vais parler en français.
The line is Can you speak to him through the interpretation and just say, I'm going to suggest, Sidi, would you mind talking to the slides? And we'll ask Professor Mukele. We'll just let Professor Mukele. We're struggling to hear.
Est-ce que je peux...
Professeur Abdon, vous avez des échos dans la salle. Si vous pouvez mettre en mute les autres ordinateurs, comme ça vous parlez directement.
It could be that, or it could just be a poor line, a poor connection. Yeah. Professor Mukele, Abdon, would you like to try talking again? Have we lost him? Sidi, do you have the slides? Or Benjamin?
Okay.
Go on, Sidi.
Yeah, Salim, can you project the slides? Please?
Perhaps, Sidi, if we could send a message through to Professor Mukele that you'll present his slides for him because the audio is just too bad, unfortunately. Are you okay with that, Sidi?
Yes,
Thanks.
I'm okay.
Great, thanks.
Sidi, can you see my screen?
Yeah.
Yes.
Okay, you'll tell me when to go to the next one.
Is it okay now?
Ok. Professeur, allez-y.
Ok, merci beaucoup. Nous allons parler de l'épidémie de Mpox et effort de réponse en cours. Un focus sur les GTCV de la région.
I think, Sidi, would you mind taking over and talking? I'm so sorry to Professor Mukele. I apologize for this. But Sidi, I think because we're running out of time, if you don't mind. Thank you.
So, next slide. Donc, ça, c'est le plan de présentation pour la RDC. Professeur Mukele, vous pouvez joindre à tout moment. Donc, je vais y aller avec les slides. Next. Ça, c'est donc l'évolution des cas de Mpox en RDC sur les 20 dernières années. Donc, on voit un peu à partir de 2020 que les cas ont augmenté pour atteindre 7537 cas en 2020 et actuellement, les dernières données de la RDC qui ont été présentées tout à l'heure par Rina, c'est environ 16 000 cas suspects de Mpox. Slide. Donc, ça c'est la courbe épidémiologique des cas suspects, des décès, de la létalité du Mpox en RDC en 2023 et 2024. Donc, on voit un peu l'évolution en dents de scie en 2023. Avec une baisse à la semaine 49 et 51. Mais à partir de la première semaine de 2024, vous voyez que les cas ont augmenté de façon exponentielle. Slide. Slide. Alors, j'ai suivi un peu les questions de la RDC. Professeur Moukalai, est-ce que vous êtes toujours ou bien je peux y aller?
Oui, je suis
Ok.
là.
Allez-y,
Ok.
allez-y.
Je peux continuer. Voici la question posée par le ministère de la Santé qui nous demandait d'examiner les données probantes et de formuler des recommandations stratégiques relatives à l'utilisation des vaccins en fonction du contexte national durant une session extraordinaire du vendredi 26 à samedi 27 janvier 2024. Slide, please. Voici, nous avons suivi les recommandations de l'OMS, commencé par la déclaration de conflit d'intérêts éventuel, et nous avons reformulé la question en ce sens, dans les populations exposées au risque d'un Mpox en RDC, lequel parmi les vaccins existants peut donner les meilleurs résultats. Nous nous sommes séparés en deux groupes. Un groupe qui travaillait sur la vaccination, un groupe sur le cadre habituel de recommandations génériques proposées par l'OMS. Slide, please. La documentation était rendue disponible par le programme élargi de vaccination, l'Organisation mondiale de la santé et notre programme national de lutte contre le Mpox et les fièvres hémorragiques virales. Nous avons recherché de manière systématique sur Internet à travers les outils comme PubMed, Cochrane, Google Scholar et consulté les bases de données de l'Organisation mondiale de la santé, entre autres SAGE, et de CDC et d'autres partenaires. Nous allons appliquer l'analyse critique des publications pertinentes, comme recommandé par l'OMS, et évaluer la qualité de ces documents. Slide, please. À travers les outils comme GRED, Darmstadt, RCA éventuellement.
Thank you. No, I think we will have to, Sidi, I do apologize to
Les études sélectionnées sur base des effets,
go back to yourself because we are
compte tenu du cadre.
It's back again. Can the interpreters hear this? Okay. We'll try one last time. Please continue. Sorry, we're having some trouble with the sound. Please go ahead.
With CD or me, please?
Oh, Prof. Mukule, it's with you, unfortunately.
Okay, thank you so much, Madam Chair.
The problem is your side. I do apologize. Go ahead.
Okay. Nous avons utilisé le cadre habituel, innocuité, efficacité, entre autres dont parlait M. Stephen tout à l'heure, les données critiques sélectionnées, les données importantes et les données non critiques. Une discussion et mise en commun de travaux de deux groupes en plénière a suivi. Une délibération à huis clos avec uniquement les autres membres sans les autres membres, secrétariat et ex-officio, et uniquement à huis clos avec les membres de droit. Et enfin, une décision a été prise, concertée. Le processus appliqué pour l'élaboration de la note de recommandation suit le modèle que les GTCV connaissent de l'OMS. Le programme élargi concernant l'expérience de mise en œuvre. Le programme élargi de vaccination a utilisé cet avis de GTCV pour contribuer à la demande de vaccins à Gavi et aux États-Unis et auprès d'autres partenaires. Cet avis sert aussi à la communication des risques et engagements communautaires. Si
So
nous
we
devons...
we'll have to speed up a little bit. I'm not sure
It's
if we're on the right
last
slide here.
slide, please.
Yeah, we will have to go a little
Wait.
bit faster because I think we might be missing some slides. Yeah, please go
Yeah,
ahead.
next slide, please. Yes, there. Thank you. Concernant les leçons sur les recommandations relatives au vaccin, comme on en a parlé tout à l'heure, commencer tôt la communication des risques et engagements communautaires, associer tôt la population, lutter contre l'infodémie et les anti-vaccinations, mener des études sur la résistance à la vaccination et collaborer avec les autres partenaires comme l'OMS, les autres nations et partenaires. Merci beaucoup, Madame Chair.
Thank you, and I'm sorry that was so difficult, but incredibly important, especially for the hearing from the DRC. Thank you very much. And I think for both of you, thank you, because it does show you that this guidance that we've been hearing about is very helpful. We won't have, Sidi and Benjamin, I don't think we will have time to necessarily have a poll, because I'm not sure how many we won't have time to do a Q&A, and we were going to have a poll of other NITAG chairs now to see who needs support. But perhaps we should ask the NITAG chairs just to indicate their presence in the Q&A. If you could let us know in the Q&A, and if you need support, if you could indicate that, and then the NISH team can come back to you and then have a more in-depth email exchange with you about what kind of guidance would be supportive. That, I think, is going to be more, I'm not sure what the poll was going to look like, but Sidi, Benjamin, will that satisfy you on what you were thinking of?
Yes, we can send later the poll to the NITAG chairs. Yeah.
Okay.
After the call. Yeah.
Okay, so your poll is online. You had some slides and you were going to, but I think the problem is that people can't, they can put in a Q&A, but they can't speak if they're not panelists. That's the problem I think we have.
So Helen and Sidi, I think Salim, I don't know technically, would it be possible just to send a link to NITAGs at this stage and they can complete the poll as we get along with other agenda items?
Yes, I can. I'll put the poll up, and then we can go and continue the webinar whilst they fill in the polls. That's not a problem.
That would be very helpful. So we'll put the poll. Where will you put the poll? In the Q&A? Will you put a link?
It's currently on the screen now.
Yeah. Okay. Okay. So how are people going to fill that in? Salim.
On their laptops or phones at the moment, they should have a little box, and they just go and answer the questions. Say yes, no. If it's a short answer, just give us a type out a little bit and give us the answer, and then we'll get the results. And in the meantime, you can go ahead with the Q&A whilst they do that in the background. I'm sure that won't be a problem.
Okay, I just tried and it wasn't taking my answers. So I don't know if it's just perhaps because
you're a panelist, yeah.
Panelists, that's probably why. So if everyone could have a look at that, and it's particularly the NITAG chairs, So, and if you're on and your chair is not on, please similarly fill in for your country. And in the meantime, do we have questions either for David or Abdon who've presented their NITAGs deliberations? Are there questions that people would like to ask to get better? So I see we've got Kenya, Malawi. Other questions? So the one from Neander, Elias and Tinginya. David, this is for you, David. Do you constitute a working group for every disease or request from your Ministry of Health? Or was this a sort of a special issue because of an outbreak? David?
Also, we do tend to constitute a working group within the NITAG that specifically looks at, whether that's the PICO questions or just any specific literature around that particular disease, and then presents to the full NITAG. And then there's some discussion.
Thanks. And so, Professor Mukley Abdon, would you have the same approach? We might have a connectivity problem there, but just to say that similarly in the South Africa.
Oui, chaque fois nous créons des groupes de travail. Yes.
Yes, and I was going to say for South Africa similarly, but in fact we will also initiate working groups if we want to look at something. For example, we had a working group looking at HPV single dose. So we will also, from the NITAG side, initiate a working group because sometimes we have information that the Department of Health wouldn't have. So thank you for that. Are there any other questions? I'm looking down. So this is an important one from, I think it's Elangiranga Kale. David, for Uganda NITAG, I did not see a representative with regulatory experience. Do you want to comment on that? It was for David. David, have we lost you?
Oh, sorry, I was muted. Can you hear me now?
Yeah, we can hear you. Thanks.
Yeah. So yes, we do have a representative from one of the regulatory. So particularly for Uganda, it's the National Drug Authority that's responsible for any regulation around drugs and vaccines. So yes.
Thanks. Celia is saying we have a rep from the National Drug Authority, Cecilia Nalwada. Is that from Uganda as well, or is that from a different?
No, she's from Uganda, from the Secretariat.
I guess, yes. Oh, thank you. Okay. So I'm not seeing any other questions, but I wondered how we're doing with our poll. I mean, there are more questions if I scroll up, but I think we should, if we can go to the poll and the other questions that are unanswered, it will come back to. There's some good questions about pregnancy, for example, and not necessarily diagnosing pregnancy and using vaccines. But how are we doing with the poll?
I think the poll is still ongoing. Definitely give them a few more minutes to get some more answers in.
So I'm going to go to Florence's question. Florence Calabamu. Sometimes it's not clear if someone is pregnant or not before vaccination, especially in poor resourced countries. So should it be a recommendation to do pregnancy and HIV screening before vaccination? So I think we're back to either Judith and or Rena. Who'd like to have a go at that?
Yes, I can. Well, I can say something. It's not before. Well, well, for the global recommendations, we say that if you would consider vaccination in pregnancy, you should not use the replicating or the minimally replicating vaccines, LC16 or ACAM2000. And you could consider using MVABN, even though this is off-label. Because, well, there is not a lot of data in pregnancy, but there is some animal data, at least DART studies. And there is some data in pregnancy that seems to be safe. So I don't know if this is something that NITAGs usually do, but in terms of our recommendations, we do not recommend this, but this might be different per country.
It does also depend, obviously, on the risk profile of who you're considering. There are a couple more questions, and Salim, you'll let us know when we've got the poll, correct? Because we're nearly at time now. So I think one of them is so for high-risk populations, can you please clarify if these are at risk of contracting the disease or for severe outcomes? So when we're describing high-risk populations, is it that the disease is more severe or that they are at a more risk of contracting the disease? Rena?
So I'm just looking at that question just to make sure I understand it clearly in the list.
Well, I think it's the list we've got. Number one, is disease severity worse in that group, or is it that we think that they're more at risk of contracting it, or both?
Maybe I can quickly come in.
Yes, Judith, you want to jump in? Yes, please.
I think generally it's probably more severe if a person contracts the disease. I don't think there's any data to suggest that there's a risk of an increased risk of contracting disease in these populations.
Well, I think that the increased risk is related to exposure. So if it's
Correct.
a sexually transmitted and you have multiple sexual partners, you increased risk of exposure. But you're quite right. I mean, if we look at children, the highest mortality, about 80% in the DRC at the moment, people who are severely immunocompromised, both from the global outbreak in 2022 and our little local outbreak that we've had here in South Africa, those are the people where we've seen deaths, etc. So exposure will increase risk, and that will be one consideration. But in most of these cases, there is an increased concern about severity. In pregnant women, there would appear to be, and Judith and Rena can correct me, limited data, but if I'm correct, an increased risk of preterm and stillbirth, correct?
Yeah, I think that's correct. Yeah.
Thanks. So I'm just making sure I haven't. Oh, so there's two more. What is the peak infectivity of the disease, and is the disease self-limiting?
Well, I can say something about that. In general, the disease is self-limiting after a couple of weeks. However, that also depends on who gets it, of course, because if you are the population we just talked about, immunocompromised persons, pregnant persons, and children might be at increased risk of contracting severe disease or severe outcomes, have more severe outcomes. And for those populations, the disease can take longer, and it can be more severe.
Thanks. And I think we've now got the poll from a number of colleagues. Salim, do you want to read out the findings from the poll?
Sure, I can. So we did not have as many people, I guess, responding as we would have hoped. 21 only, so we will be, I guess, sending it out after the webinar again. I can share my screen and then you can talk through some of the responses we got very quickly.
I think it might be because we said the chairs. So we might have limited the numbers of people responding.
Yeah.
So I think that probably answers that. But from what I'm seeing is your NITAG currently working on Mpox vaccine recommendations. So 29% yes, 71% no. And it could be that some of the colleagues here are on the call precisely because this is something that needs to be considered. If yes, what is the broad policy question? Short answer, well, I'm not sure that what we've got. Salim?
Can you see my screen here?
Yeah, we can.
Maybe I should zoom in. There are some responses that we got. So
Okay.
should Uganda introduce a vaccine?
Community transmission, yeah. I requested last week to come up with ETR, currently working with the Secretariat to set up the initial meeting, okay? Work on WHO recommendations. We are waiting for the Mpox question from the Ministry of Health. NITAG makes recommendation to the Ministry in this regard. Should Mpox vaccine be introduced in Tanzania, question mark? Under what circumstances and which population should be vaccinated? If so, what type of vaccine? What are the implications, both technically and programmatic? So these are very good questions. I'll add one that came up today that isn't necessarily strongly in the current WHO SAGE recommendations, and this came up from the South African discussion. We've already got recommendations in response to our outbreak, which is looking at both post-exposure use of a vaccine and pre-exposure. One of the things that's come up now, though, is about travelers. We have particularly two groups of people who are going up and down to the DRC. One is in the mining industry with about 5,000 engineers, etc., moving up and down. The other one, though, and I think everyone should just think about this, is the military, because we have, I think, with the AU/UN intervention in the DRC, our military is going up and down. And as we know, with the military and with the heterosexual spread, and with mining engineers are mostly men. So this is a consideration. So one of the things that we should also think about when we think about occupational exposure is, occupational exposure through traveling. And we might find that there are more because these are, as we saw, many of the countries have got not only population movement across the borders, but also they'll have security and other groups. So that would be another consideration for people perhaps to think about, which we hadn't previously thought about here. So the next question, who's working with a PICO, not started. Yes, hepatitis B. A lot of people are trying to sort that one out. That's a bit complicated. So working with PICOs, I think people are beginning to do that, but not every question lends itself to a PICO necessarily. What additional support is needed to issue a recommendation? Collation of evidence. Well, thank you very much for the library. That's incredibly useful. Inclusion of the National Regulatory Authority, mathematical modeling scenarios of disease spread. Collecting evidence is usually a problem, but should be fine with access to the NISH library. More capacity building for better understanding. That, please feel free to ask that, because not everyone's ever used a PICO. Not everyone's ever looked at evidence to recommendation. So I think the whole point about this initiative is to actually assist people. So if you feel that we've never done this, we need help, please go ahead and make that request to NISH as well. Just one comment on the regulatory authority being on the NITAG. I mean, that clearly is an option. But it sometimes, and I can say this because I chair the board of our regulatory authorities, well, sometimes regulators take different decisions. NITAGs are not infrequently will take an off-label decision, whereas a regulator has to look at the data that's presented and be quite rigid on only being able to recommend in terms of risk-benefit what's in front of it, in terms of the data that's presented in a dossier. Whereas NITAGs are able to look at observational data, data that's not necessarily presented. You will never see probably a package insert saying you can use a single dose of HPV, but a lot of NITAGs have recommended that, and the RITAG has, and SAGE has. So the considerations between the two are somewhat different. So I think just to flag that they don't have to align. So that's just a comment from me. So we've gone over time, and I do apologize. We'll make the poll results available to everybody, but it would seem that there's it would be very helpful for NISH to reach out to everyone who's been on this call, who the chairs, and just say who would like to have some further support in this. So with that, let me hand over to Charles and Benjamin to wind up. Thank you from me, thank you so much. It's a very, very rich and important discussion because, as we all know, the rubber hits the road in the countries. So thank you very much. Benjamin, I don't know if Charles is on.
Thank you so much, Helen. Is Charles on? Charles, do you want to go first before I come in?
Perhaps he's...
Yes.
Oh, there we are.
Hi,
Okay.
Helen. Yeah. How are you? So, yeah, so just to thank you, Helen, for making the time to chair this session, to thank all the NITAGs, their presidents, and the members who are here present, all our partners who NISH and all the other partners who contributed to this. I've followed the discussion and they are quite exciting. And like this is not the end, it is the beginning, and we like the NITAGs to engage with each other, to get in touch with us, get in touch with NISH when they're having any questions around this. So thank you so much to everybody.
Thank you so much, Charles. And again, thank you so much, Helen, for making time to chair this brilliantly, as always. And just to say to the participant and to the partners involved, this has been excellent. This is possibly the forum that is very focused on NITAG's interest in the context of issuing recommendations that the government can use to make it possible for government to access vaccines and other type of response in the context of responding to Mpox. And just a few things, just from the presentations that have been said, there is an issue of evidence gaps, and I think it's up to us as NITAG support partners and all those who are involved in supporting the work of NITAGs to work together collaboratively in ensuring that we support the NITAGs in making the best timely recommendations that the ministries of health will find it fit for purpose in response to the work of NITAGs. Thank you so much, and very happy to be part of this. And with that, I think, Helen, we end the webinar. And from the poll, we might have to possibly constitute another webinar to discuss this further, because the outbreak continues to grow in the continent, and there is very specific issues that as a region we need to think about in terms of evidence gaps. Thank you.
Thank you very much.